Yeah, thank you, Dr. Nidhi. At the outset, I would like to thank the entire team for inviting me here all the way from Vellore. Special thanks to Dr. Amaddeep Kaur and Dr. Shivam Gupta. So I'll be speaking on visual field analysis, a checklist for correct interpretation. So when you are facing a visual field report like this, you will be having multiple questions, whether this field is reliable, is it even glaucoma, is it relevant, or is there a progression? So why so much confusion is because visual fields are very subjective and they are highly variable. And you can end up with an overdiagnosis or a misdiagnosis, and that is why we need a checklist. So this is the traditional way of having the visual field printout dividing into various zones, and I will take you through each zones and I will be highlighting few points in each zones. So the zone 1, the patient or the test data, yes, it is very important that you identify the patient correctly and also look at the eye which is being tested. Apart from that, importance of age. So why age is very important? Because the entire visual field printout, most of the data is based on age match normative database. So I have a question for you all. So if the age is entered incorrectly, but all the other parameters are normal and reliable, do you ignore these tests completely, or you will still go on to look at this printout for something else? So the answer is these 2 points, the raw data and the grayscale. These are independent of any age match normative database. This is the actual data of the patient, not based on any age match normative database. So you can still have a look at these 2. So next is the pupillary size. Yes, 3 to 4 millimeter size is the ideal size of the pupil. Many have a question, can we do the visual field in a dilated pupil or not? Yes, we can indeed do a visual field in a dilated pupil, but the only point that you should keep in mind is that when the patient is coming to you for follow-up, you have to see that this is comparable with the previous field report, same pupillary size. What happens when there is small pupil, less than 3 millimeter? You will have a diffuse visual field depression or scotomas. So let's have a look at this field printout where you are seeing that the pupil diameter is 2 millimeter and you are seeing so much of scotomas. When the same visual field is being done with a pupil diameter of 3 millimeter, the scotoma disappears. So next is the refractive error. So what happens if proper refractive correction is not given? You can end up with a generalized depression in a field. Also note that the glasses should be placed properly in a trial frame, or once again you are going to land up with an edge scotoma. So one more point I wish to highlight here is that the visual acuity should be explained by your foveal threshold. So if you have a look at this particular printout, you can see that the visual acuity is 6 by 6. But when you look at the fovea, it is around 29 decibel. So fovea is the point with the highest sensitivity. So highest sensitivity means it should be something close to 40 decibels. So if this correlation is not there in your visual field printout, once again the reliability will decrease. So HFA 3 has come up with something new, that is the liquid trial lens. What exactly happens in the liquid trial lens? There is automated measurement of the refractive error and you don't need to change the lens in the trial frame. So this is once again another example. So there is no refractive error correction given here. So you can see that the visual acuity as well as the refractive correction is not there. So if you see the next printout, you can see a 7 diopter sphere is given. So the generalized depression in the total deviation plot completely disappears. So next is the test data. So the fixation is being monitored by 3 things. That is the Hagel-Krakow method of fixation monitoring. For what actually happens is that the periodically a stimulus is being presented to the patient's blind spot. So if the patient responds to the blind spot, that means the patient is not actually fixating. So next is one more technique is the infrared gaze monitoring. So this is how the infrared gaze monitoring looks like. So you can see this large eye deviation. So something above the baseline, that is a large eye deviation, and something below the baseline is a blink. Ideally, a good steady fixation will be looking like this. So once again, this is another example. So exemplary fixation will have short spikes, but not like this. This is a large blink and large eye deviation, how it looks like. So, in the printout, you will see the infrared gaze tracker here. So, next is the targets. So, the central target is the usually used target, and you have the large as well as the small diamonds. So, when exactly is the large and the small diamond comes into place when you are having a macula pathology. So, let us have a look at this. So, in this particular printout, we have used a fixation target of central. So, you are having a diffuse defect as well as a defect in the pattern deviation plot as well. When you change the fixation target from central to diamond, look at the difference. So, small things makes a whole lot of difference when it comes to visual field. Next is the reliability indices. I already spoke about fixation loss. Apart from fixation loss, you have false positive when the patient responds in the absence of stimulus, and false negative due to fatigue or lack of attention. Once again, here I wish to highlight the fact that false positive and false negative, you will give more importance to false positive, because false negative, it can happen even in advanced glaucoma, because the patients will have small shifts of fixation. So, false positive is one of the key factor. Next is the raw data. As I already said, this is very important. So, if all the zones are normal, but you will still have a clinical suspicion, go and have a look at the raw data. Let us have a look at this example. Here you can see all the central points are having some sort of values, but when you start looking at the periphery, everything is 0. So, less than 0 actually indicates absolute scotoma, while 40 is the maximum sensitivity in which the patient will respond. So, next is the grayscale. Yes, you can have a look at the patterns in the grayscale and you can use it to explain the condition to the patient. However, we do not do a diagnosis based on the grayscale alone because of this particular reason, because there is extensive interpolation happening. So, what exactly is interpolation? Because the in between the locations that are not being tested, it is assigning a color code. That is why the diagnosis is not done based on grayscale alone. Next is the total deviation plot. So, it has a numerical and a probability plot. So, the numerical plot, the raw data is compared with the age match data. So, here comes the age match database comparison. So, you are going to know the degree of the deviation of patient's retinal sensitivity from the normal. So, when you come to the probability plot, I will make it simpler. The darker the symbol, the greater the probability of being abnormal. Next is the pattern deviation plot. Once again, this also has a numerical plot and a probability plot. So, this is to highlight the glaucoma part. So, it is modified from the total deviation plot to bring out deep hidden scotomas. So, if a patient has both cataract and glaucoma, to bring out the glaucoma part, we need the pattern deviation plot. So, this is done based something called the 7th best sensitivity point, which the machine does automatically. Next is the global indices. So, you have the mean deviation. So, if you want to give a single digit to the total deviation plot, that is the mean deviation what it is representing. So, it is the average of numbers shown in the total deviation numerical plot, very simple. The pattern standard deviation, it quantifies localized loss. So, these are the global indices. So, next global index is a visual field index, which is very important. So, once again, this is an enhancement of mean deviation, but the point you have to note here is it gives more importance to the central points. The weightage for the central points is more with the visual field index. So, what happens here, you can see in this example, there are only 5 points that are being affected. However, when you see the visual field index, it is 87%. That means the central points, 13%, that is being affected just by 5 points. So, the visual field index, the central weightage is more. So, next is the glaucoma hemifield test, which is specifically designed for glaucoma. So, with the horizontal line above and below, 5 zones are being tested and compared. So, this is an index to detect early glaucoma. The messages will be displayed like borderline, abnormally low sensitivity, high sensitivity, outside normal limits and within normal limits. So, what exactly is GHT outside normal limits means that the difference between any zone in the upper and the lower zone is found in 1% of the normal population. So, this is not normal. So, 99% won't have this, only 1% will have this. So, that is the meaning of GHT. To summarize, first verify the patient and test data. Decide whether this test is reliable and also appropriate for your particular patient, and decide the type of field defect. Keep in mind, rule out artifacts and correlate clinically. I'll end with this particular example. So in this particular patient, you can see this is the right eye of the patient and this is the left eye of the patient. In one glance, what do you feel? You feel that the left eye is more affected than the right eye. So let's have a look at the other things. So this is the fundus photo. So in actually, if you see, here you can see an Arnefeld defect, down you can see an Arnefeld defect, but at the same time this is the left eye. So this is a left eye disc, this is a left eye field, right eye disc, right eye field, and even in OCT, the damage is more in the right eye, not the left eye. So I would like to have you go home with this message. Clinical correlation is the most important thing. It is of paramount importance. I would like to take a moment to thank my mentor Dr. Devendra Maheshwari and my academic team at Tirunelveli and my current team at I Foundation Vellore. Thank you.